Welcome back to Psychiatry Bootcamp. We are going to pick up right where we left off with delirium. We're going to discuss the pathophysiology of delirium and then an approach to treatment for delirium. I know that you will appreciate the depth of understanding that Dr. Oldham brings us, and especially his creative analogies for conceptually understanding delirium. We are picking up mid-conversation, so stand by.
Okay, so often I've heard delirium described to patients or to patients' families as it's a sign that a patient's medical illness is significant enough that their brain, their central nervous system is no longer able to maintain proper balance. That is, homeostasis is disrupted in the central nervous system due to some organic insult. But could we be more specific here about what that organic insult is? Do we know anything for sure about the neuropathophysiology of delirium? What neurotransmitter systems are involved? Any circuits that we should be aware of? Is there any settled science in this area?
So I think the science is becoming settled regarding the final common pathway. What is less settled is this idea that there are perhaps many different physiological pathways to achieve that final common pathway. And so the final common pathway currently is kind of understood as systems failure. So essentially, we talk in terms of networks in the brain that subserve kind of these complex functions. So the default mode network has got a lot of press the last couple of decades. And this network is involved in kind of self-reflection, internal focused cognition, and you're not doing anything, but your mind is active and you're thinking and you have internal narrative, things like that. And so that's, again, internally focused, and you're not actively, consciously doing other activities. Then you have kind of this, broadly speaking, and there are a couple of different networks that kind of fit into this, but broadly a cognitive executive network, or in other literature, a task positive or a task on network. So that when you are actively doing something, that network turns on. So if you're doing something that requires attention or focus, or you're doing mental math or things like that, problem solving, that network is on and the default mode network turns off. And so these are supposed to be anti-correlated, which is to say that it's a switch. One turns on, the other turns off, and vice versa. And then you have something right in the central prefrontal cortex into the anterior cingulate that involves what's called the salience network. So things that are salient in the environment, or even things internally that are salient. And the salience network is involved in that flip-flop switch, turning the default mode network off and the task positive network on, and vice versa. Now, in health, it should be one or the other. And the salience network should sit at the middle and say, okay, now we're going to pay attention to this. Now we don't have to. Now let's kind of turn inwardly and relax. We're not focused on something outside. In delirium, that anti-correlation of the default mode network and the cognitive executive network is disrupted, such that you get a bleeding in of both internal and externally focused things, and the salience network is not arbitrating appropriately between the two. And just imagine if you couldn't focus on one thing when you wanted to, well, what would you have? Well, you'd have inattention, and you wouldn't be aware of your surroundings, and you wouldn't have appropriate salience, and things wouldn't make sense. So at a final common pathway level, again, we think that these two networks are not appropriately organized by way of the salience network. Now, the questions that I find particularly fascinating pertain to thinking about delirium not as one thing, but as many things. So delirium represents the convergence of many different physiological disturbances, right? So you could get there by way of alcohol withdrawal, DT is delirium tremens, alcohol withdrawal delirium, and that is a state of hyperglutamatergic activity. So your glutamate is on, your NMDA receptors are active, and it's a time of increased excitatory tone. And we treat that with benzos. So yes, we do treat some delirium with benzos, but then there are other deliria that come by way of oxidative stress, or maybe they come by way of an intoxicant like an anticholinergic toxidrome. And so I think you can get there by many different pathways, but ultimately, all of the pathways, and it's a fascinating thing, they tend to converge at this thing that we call delirium, where physiologically, these brain networks are no longer appropriately coordinated for internal and external task positive, task negative networks in terms of activity.
You have an absolutely amazing way to break down very, very complicated topics in ways that are very easy to understand. I think that's very clear for our listeners. Is there anything you want to add with regard to the neurotransmitter systems?
Yeah, I think maybe one other thing I might mention is the idea of I wrote this in something online recently, more as a thought piece, but I think a lot of people, when they look at delirium, they think of it as something to be avoided, something to be, how should I say, eliminated. And by the way, I'm against delirium. I'm anti-delirium. I don't think we should have more delirium. But I do think that delirium deserves its due for its value in telling us something about what's happening underneath the hood. And what I mean by that is I think of this analogy of like the blue screen of death, right? So when you're on Windows and the operating system crashes and you get a blue screen of death, the blue screen of death is not the enemy. Like they could have coded Windows differently without a blue screen of death, but it would not have made the system any more stable, right? So the fact that we have something like delirium that is an index is, I think, in some ways more of a feature than a bug in the system. And similarly, we can think about starting a computer and turning it in, like after the blue screen of death, and you go into safe mode. Like safe mode is not the problem. It's good that you can turn your computer on and access core features so that you can do the work you need to do and then turn it off and on again, and poof, things reset. That's like sleep. I think sleep in some ways resets the brain. Have you tried turning it off and on again? So a really healthy physiological sleep can help. So the physiology of delirium is in itself, I don't think the problem, but it's an index. And so maybe if we reconceptualize delirium a little bit, we may have a rapprochement with delirium as a concept as we begin to make inroads into understanding some of the nuance of the condition.
Right. It serves an important function for us clinically as doctors to know, hey, there's some disruption to homeostasis that we need to figure out soon. But also it makes you wonder evolutionarily, how was it helpful for us? That's a really interesting concept. Okay, so the $1 million question here, and you've alluded to it somewhat. How do we treat delirium?
Yes, I think in this regard, I'll dispense with the idea that antipsychotics cure delirium. We can dispense with that pretty easily. Delirium is not Haldolipenia. It's not a deficiency of antipsychotics. But I guess in a way, I'm going back to some of the things I've already said, but perhaps extending upon that. Our model of delirium, how we understand the broader diagnostic construct, should guide a rational approach to delirium treatment. So the model of delirium that I've talked about, it's not widely accepted as a model, but it's something that I'm trying to advocate a bit more for, just largely so that we think more comprehensively about the different kind of levers that we can pull for delirium and clinically management in a comprehensive fashion. I think of it as having 4 elements. So you have the proximal precipitant or precipitants, so all the things that caused delirium. Then you have the downstream pathophysiology. Some of it might be inflammatory, some of it might be anticholinergic toxidrome, some of it might be excitatory excess with glutamate and the like. And then you have the clinical phenotype itself, delirium, plus minus neuropsychiatric disturbances. So those are the 3 canonical pieces of delirium, at least as I think about it. And then you have all these other factors for cognitive health. So we could say that these are they promote cognitive health. They're pro-cognitive in that regard. Or we could say that this is cognitive or physiological resilience or cognitive reserve. And so that might be another area. So when we come to the patient who has delirium or is at risk for delirium, you can think about prevention in a moment, but when the person has delirium, we need to shore up all of these procognitive factors that will inform the broader kind of patient in context. So that includes things like cognitive stimulation, engagement with people around them, getting up and walking so that they don't become deconditioned, making sure that they have their glasses and their dentures and their hearing aids if needed. That's, by the way, I don't even consider that treatment. That's just like good humanistic care. Like, it's not treating delirium, but we should be doing these things. But if we want to put them under the banner of treatment, so be it. Fair by me, as long as we do it. So that's treating these contributors to delirium. Next, we treat the underlying cause or causes. Very often there's more than one, but sometimes there's just that one. So it could be sepsis, or it could be the person has acute kidney injury, something like that, right? So you treat the underlying cause. I'm going to skip the pathophysiology for just a moment and come down to treating delirium, the clinical phenotype. And that is, we don't have great, again, delirium-specific treatments. But when we really begin to think about psychopharmacology, and we can unpack this in a moment, the psychopharm that we're using is not for delirium proper. It's for discrete neuropsychiatric disturbances. So if the person is distressed, if they are paranoid, if they are agitated, if they have akathisia, right? All of those things, those are the clinical syndromes, the clinical symptoms, clinical signs that we are addressing by way of psychopharmacology and also non-pharm treatments to shore up a sense of safety, engagement, family involvement, those kinds of things. So we can manage delirium at that level. And then finally, getting back to the pathophysiology, I think this is the area that's most interesting for the current delirium research space. And that is really beginning to unpack what those physiological disturbances are. Because that really is, I think, should be the future of delirium research, understanding the different subtypes, physiologically speaking, of delirium. Because it may well be that a lot of people with delirium can be treated with things like physostigmine or cholinesterase inhibitors. Maybe there's a subgroup of individuals that preferentially will be improved. Their symptoms will be improved with that intervention. Maybe there are individuals who have a dopaminergic excess, and antipsychotics that block D2 are specifically, uniquely effective. We know that somebody who has valproic acid-associated hyperammonemia, we can use levocarnitine. It just jumpstarts the ammonia breakdown, and so it reduces ammonia. So again, if we understand these physiological intermediate states between the proximal cause and the phenotype, I think that offers us a great deal of insight and offers us novel treatment targets to move the field forward and to begin to surgically kind of cut these out and identify them as codified, biologically defined delirium states.
And I think that conversation speaks to why we don't have a single agent or a series of agents that actually treat delirium. And it's because of the reality, which is these are multiple different physiological phenomena which are manifesting as delirium. And so to think that we would have one cure for all of these various disruptions of homeostasis is a little bit silly after all. So you're suggesting we definitely work up and treat the underlying cause to promote overall brain health, things like sleep, making sure that the person has all of their sensory modalities functioning as well as can be possible, nutrition, mobility, etc. And then targeting specific, I believe you said, neurophysiological sequela, which to me sounds a little bit like symptoms if we have a targeted treatment.
Oh, so neuropsychiatric disturbances.
Neuropsychiatric disturbances.
Neuropsychiatric, yeah. So when we think about dementia, right? So there's the behavioral and psychological symptoms of dementia. And then one other way of saying that is the neuropsychiatric symptoms of dementia. I don't like the word symptom because symptoms are subjective, usually, if you want to be a purist on the word. So I want it to be broader in encompassing not only symptoms, but signs, and that includes behaviors. And so disturbances, I think, is a broader construct. So that's why I use the word neuropsychiatric disturbances, because it encompasses the internal experiences, symptoms, the distress, the paranoia, things like that. But it also includes the behavioral disturbances and the other kind of clinical manifestations that are objectively evident when you're engaging with that patient. So that's why I use that term.
Gotcha. Thank you for being granular with us. I think that's going to be really, really helpful and enlightening to our learners, especially our learners in training like myself. Any other specific strategies you want to recommend in terms of optimizing brain function?
I think, yeah, I guess my only answer to that would be what we've already talked about, which is the idea of things that promote brain health. I mean, there are what we call broadly delirium bundles. So that's a term in the literature, a term of art, delirium bundles. So that they're effectively kind of codified sets of brain health promoting, usually non-pharm interventions that, again, promote healthy cognition, socialization, good sleep, things like that. And so perhaps two of the better known ones of these, and they're actually broader than just delirium bundles, would be the HELP model, so Hospital Elder Life Program. This is very often heavily volunteer and nursing based interventions that promote elder health in the hospital. And one of the major benefits is by reducing the rates of delirium, also preventing things like falls and deconditioning, things like that. And then generally on geriatric floors or other hospital medicine type floors. And then in the ICU, the kind of the broader bundle is called the A to F bundle. So sometimes abbreviated A, the letter A, the number 2, the letter F, which is cute and simple. So I like that. And I'm just waiting. I'm genuinely waiting for them to get to Z, because like they'll get to Z. Just give them time. I have every faith that we'll get to Z, A to Z. But essentially, these are things that focus on limiting potentially deliriogenic medications, spontaneous awakening, spontaneous breathing trials. That's the kind of the A and B kind of idea in there. Choice of sedation, and then going all the way to F, family engagement, family involvement. And so I think, again, these are things that support, but not only brain health, these have a panoply of benefits that go beyond brain health. So on the one hand, yes, they are cognitively beneficial, but they also provide, I think, systemic benefits and recovery focused, dispositionally focused or dispositionally minded benefits as well.
As someone who had not spent a whole lot of time in hospitals until starting medical training, it was surprising to me, and even now still a little bit, that they're not always, it seems, places of health in some ways. They're places where we work up, identify, treat acute diseases, but not always terribly, globally speaking, healthful for our patients while they're there. And I think that navigating these systems, making these systems more healthy can be really tough, really daunting for a trainee, especially like a resident. And in ensuring adequate treatment for our patients who have delirium, a lot of this goes beyond medicine. It's more advocacy, how to work well in the hospital, how to play well on a team. You alluded to some of this earlier. Just want to know from your hard-won wisdom, any like rock-hard tips about how a resident can be a good advocate for their patient in this way?
Yeah, so I'm going to echo something you just said, which is that, and I say that I have a love-hate relationship with hospitals. I work in hospitals, I do research in hospitals, so I totally appreciate the dynamics of the hospital setting, and it really is something of almost a miracle, the kinds of things that modern medical science can achieve these days. But hospitals are the worst place for sick patients to be. We want to be able to discharge people home as soon as possible. The longer people are in the hospital, it's just an environment with so many potential perils. So totally appreciate that. In terms of advocating for patients, I guess it really depends on how ambitious the resident or trainee might want to be. So for instance, on the one hand, at a very direct patient care level, providing education is really important. Providing hands-on education to other trainees who might be younger than them, and so that helps consolidate their own knowledge. Providing meaningful education to the person consulting them if they're, again, working in a medical surgical setting. Providing hands-on care to teaching training to the nurses who happen to be at the bedside and asking them about what they've observed, how they've been doing it, and then maybe even the nurse to go with them, asking the medical team to go with them if they happen to be right outside the room or on the unit, the nursing station, and say, let's go see this person together real quick. I just want to confirm what we're talking about, what I'm seeing, and so maybe we can compare notes and see how people are doing, because very often we're using words in psychiatry that maybe other people aren't using the same way. So when we say that the person's not paying attention and the medical team is saying, well, they answered my question. They clearly are paying attention. Well, we're saying they don't pay attention. We mean they can't, let's say, sustain attention. And we're doing a task to show it. So I think that's kind of hands-on, one-on-one or small group kinds of education. Higher level than that, one might think about doing educational initiatives, so providing kind of in-services or providing education, so doing different noon seminars and asking to be able to present in different forums to our colleagues to provide a shared language, just in the spirit of education, just sharing clinical pearls about evaluation, management, and so forth. And then we could elevate this one step further. But again, this is where I'm saying, like, how ambitious does the resident want to be? When you're really getting at systemic change in a hospital, it's tough. So when you want to change the electronic medical record, you can't just change it usually in one unit. If you're going to make a change, it's going to have to be signed off on at a much higher level. So if you really want to add, oh, let's say we're using this instrument and it's not really working out and you want to change to a different instrument, that's going to take a bit of work. Or if you want to do a delirium order set, or if you want to do a delirium list, or if you want to promote delirium on the story page of your electronic medical record, the login, what have you. These are some of the kind of implementation things that we've kind of done at our institution at the University of Rochester. And again, I think they really advance and enhance care, but they are longer term engagements and they require sustained advocacy over a period of time and really networking with people across the institution outside of psychiatry, because delirium affects everyone. Delirium affects every specialty. It affects all the different clinicians and disciplines. So in that regard, it depends on how much energy and time and advocacy a person really is able practically to invest.
No, that's very practical for us. And it's not a sprint. It's probably more of a marathon to change hospitals. But also you reminded us that education is power. Education can be very helpful for our patients by educating family, by helping to educate staff, by spreading the good news. I think where the rubber hits the road, you can really help your patient out.
Psychiatry Bootcamp is brought to you by Beat the Boards. I am so excited to have Beat the Boards as a partner because this is the question bank that I used to study for my own psychiatry board exam, and it made the exam a breeze. The Beat the Boards question style was so close to the style of questions on the real exam that I felt over-prepared during the test. Beat the Boards has courses in psychiatry and virtually every other area of medicine. Visit beattheboards.com to view the entire catalog and take advantage of Psychiatry Bootcamp's exclusive additional 10% savings by entering the word bootcamp in the referral line in the shopping cart. Again, unlock these additional savings with referral code BOOTCAMP. That's one word, no spaces, bootcamp. Psychiatry Bootcamp is brought to you by Simple Practice. Are you thinking about starting your own practice, but you're too daunted by the business and logistics? Or maybe you have a practice, but you're spending so much time on scheduling, record keeping, and billing that it's burning you out and slowing you down? Simple Practice is the solution for you. Simple Practice is an all-in-one EHR designed to help practitioners thrive. From admin work to clinical care, Simple Practice has a suite of tools that work together to simplify practice management. This includes e-prescribing and PDMP checks integrated within the app, and a lab slip template that can be easily sent to patients within the portal. With Simple Practice, you can spend your time on what matters most. For an exclusive 7-day free trial and 70% off 4 months, visit simplepractice.com/bootcamp. That's simplepractice.com/bootcamp.
Okay, so pharmacology of delirium strikes me as a particularly sort of, I don't know if controversial is the word, but definitely intriguing area. We've teased it a little bit. We've made fun of what may be a very helpful agent, as a matter of fact. What does the evidence tell us about pharmacologic management of delirium?
What do I wish it showed us that is very different from what it does show us? So historically, the pharmacological treatments of delirium have treated delirium as all-cause delirium. And the question is, can we find a medication that is an antidote to delirium? That's how it's been approached. And I'd like to come back to this idea of all-cause delirium a little bit later. But what we have found is that if you block a whole bunch of D2 receptors, arguably the majority of them, that does not cure delirium. And I'll just cite the Mind USA study. It was a great ICU study that investigated the use of haloperidol and ziprasidone, pretty assertively dosed, by the way, agents for the management of delirium in the ICU. And lo and behold, haloperidol and ziprasidone did not cure delirium. So we know that by just blocking more D2 receptors, we have not ipso facto reversed delirium. So what do we know? Delirium is not inherently a state exclusively of too much dopamine, and if you block enough of it, you reverse it. But that doesn't answer the questions that I think we all really want to know, which is, well, if a person is agitated with delirium, so we'll say hyperactive delirium, which is hyperactive is just a descriptor of too much activity. It doesn't mean anything necessarily intrinsically, but a person who is hyperactive, agitated, activated, and has delirium, I think what we want to know is if we use a medication to treat this, will we improve the hyperactivity, agitation, what have you, better than if we had just done nothing or placebo? And in fact, there was an interesting study a few years ago where this was in a palliative care kind of oncology setting. It was published in JAMA. And essentially, this study enrolled people with hyperactive delirium, and they were given haloperidol in a scheduled fashion for 48 hours as kind of a run-in. And anybody who still had hyperactivity at roughly 48 hours, I believe it was, were randomized to receive either 3 milligrams of lorazepam or placebo. And the question was, which of these agents, or did lorazepam in an otherwise benzo-naive individual, 3 milligrams, a pretty substantial dose, did that improve the hyperactivity in these patients better than placebo? And it was an 8-hour follow-out study, and they tracked the RAS over the course of 8 hours. And they found that lorazepam slightly, a little bit faster than placebo, helped put people to sleep. But when you look at the average RAS, most people were pretty much asleep. But when you look at the kind of the placebo group, I think this is the more instructive and interesting finding. Their average RAS was between 0 and -1 within about an hour or so. And our target RAS in the ICU is usually 0 to -1, not asleep. And so I think very often when we give agents to patients and we think, oh, look, now they got less activated, we attribute the change to our intervention. But sometimes, as this study I think shows pretty nicely, if we had done nothing, the natural course of this outlying clinical phenotype of hyperactivity would have been to regress to the normal. We were not sufficiently regressive in our projections effectively. And so to be a little cautious about overinterpreting the kind of clinical outcome based on what we gave the patient. So that's really a question of attribution. But what do we know about different phenotypes of delirium and what might medications do? Now, I'm going to go beyond the current evidence and just map out perhaps a few things that I'd like to know and some clinical tips that I know I've heard from a number of colleagues around the country about how we might think about this and what agents might be thought of. So if a person has agitation, antipsychotics are, to date, really the agent of choice in most deliria. Haloperidol can be beneficial over a number of other agents simply because it has multiple routes of administration, including IV, and it doesn't have any anticholinergic properties really to speak of. So in that regard, you're not theoretically worsening the cholinergic deficit if that happens to be playing a role in that patient's presentation. At the same time, quetiapine, olanzapine, risperidone, other atypicals may be considered in certain patients. They have perhaps a little better mood regulation properties. We think about them in bipolar disorder. And so maybe applying that to an individual who has those same symptoms in delirium might be appropriate. We know that all three of those agents, olanzapine, quetiapine, risperidone, are sedating. And so it's not uncommon to give a higher dose of those agents in the evening before bedtime. to help facilitate healthier, more physiologically restorative sleep. And so again, that's a common practice. If somebody has perceptual disturbances, certainly an antipsychotic might be considered in that context to treat the psychotic symptom. Although I'll just throw out there, maybe it's not D2, maybe it's more serotonergic. So we think about pimavanserin as a serotonin 2A inverse agonist to treat hallucinations in Parkinson's disease. It's not an anti-D2 agent. And yet somehow it could well be that serotonin 2A and other serotonin receptors play a role. Again, an unexplored area, an interesting question, but we do know that a number of the atypicals block serotonin 2A. So maybe there is some added benefit for atypicals in managing psychotic symptoms or perceptual disturbances in delirium. Again, kind of just thinking about what we know in other contexts. But then beyond antipsychotics, right, there are a number of other agents that might be considered. I already mentioned earlier, benzodiazepines are used to treat alcohol withdrawal delirium. Benzodiazepines may be used in other states like anti-NMDA receptor antibody encephalitis, serotonin syndrome, NMS, neuroleptic malignant syndrome. So benzos may be reasonably appropriate in those contexts, or other delirium that happens to present with catatonic symptoms, maybe a lower dose of a benzodiazepine. Beyond kind of the two that we always talk about, benzos or antipsychotics, we could get to alpha-2 agonists. So dexmedetomidine is an IV infusion. It's a sedative, but it's not GABAergic. We know that dexmedetomidine can prevent delirium in the ICU, even when given lower dose at night relative to placebo. We know that it really tamps down on some of the sympathetic activity, the activation physiologically, so it can be beneficial to manage some of the agitation in delirium, provided it's medically appropriate, thinking about vital signs and so forth. As a result of that, some people have begun to explore the use of things like guanfacine and clonidine, which are oral agents, guanfacine with less of an effect on blood pressure than clonidine. Clonidine, though, can be given as a patch, which is an interesting opportunity here. And then beyond those, I mean, it's an interesting and open slate of other psychopharmacology. Gabapentin or gabapentinoids could be used for akathisia and restlessness. So again, if someone's constantly moving, we might think about using something like a beta blocker, propranolol, a non-selective a beta blocker for akathisia, again, gabapentinoids, things like that. Let's see. And then I think I guess one other flip side of this is, what if the person has delirium and they're hypoactive and they're not engaged? Is psychopharmacology relevant there? And I would say that it can be helpful, kind of speaking clinically, anecdotally, but not a lot of great data yet. Things like modafinil are kind of non-stimulant wake-promoting agents that could be given in the morning to help people stay awake during the day, which helps them consolidate sleep the next night. Stimulants might be considered, low dose, definitely not getting much past, let's say, noon, 1 o'clock, because you don't want to keep them up the next night. But stimulants can be helpful to engage people to combat the abulia, the inanition, the lack of engagement, to help people ambulate, to be engaged cognitively, socially. Certainly caution about cardiac status, also caution if somebody has perceptual disturbances or psychotic symptoms. Obviously, stimulants can make that worse. Again, I'm just painting a picture of a variety of other psychopharmacological interventions that might be reasonable in selected patients, considering risk-benefit ratio. What exactly are we treating? What do we want to achieve? And how can we help facilitate recovery in this patient, again, based on the neuropsychiatric disturbances that they have?
So no treatment necessarily indicated for the delirium itself, but depending on the full clinical picture, there may be some reasonable options for specific neuropsychiatric disturbances that you want to target. Is that right?
Yeah, exactly. That's how I clinically approach it. I mean, if we go back maybe 10 years, 20 years in the literature, I'm not so sure that was as common a way of talking about it. And again, I'm kind of drawing an analogy from the way that we think about dementia. So the last couple of decades in the dementia literature has really begun to articulate what are the neuropsychiatric symptoms, neuropsychiatric disturbances of dementia. And how do we best, one, define them, but two, how do we treat them? And which of them is more common in which type, pathologically speaking, of dementia? So Parkinson's disease, or dementia with Lewy bodies, or Alzheimer's disease, frontotemporal dementia. And so a lot of the work has really been pairing underlying neuropathology with discrete neuropsychiatric syndromes and neuropsychiatric disturbances. And I think that kind of approach, I think the dementia literature is like decades ahead of the delirium literature. Right now, we're just talking about all-cause delirium. Dementia used to be all-cause dementia. Now, when you say all-cause dementia, in fact, that feels like we're going backward, right? We're increasingly wanting to specify not only that it's Alzheimer type, but now we're talking about specific kind of taxonomies of Alzheimer's disease based on whether it has certain CSF findings or imaging findings and the like. And so as we grow in specification in Alzheimer's disease and related dementias, that kind of specification, I think, should also apply in its own way, physiologically speaking, to the delirium field. And then superimposed on top of that are these neuropsychiatric disturbances. And I think targeting these unique disturbances could be very clinically actionable and a way to get traction in an area that we have really wanted for traction, really since time immemorial.
You're giving us a really exciting look into kind of the future of psychiatry. So I'll be doing consults next year when I start my life as an attending, and hopefully for who knows, for a long time, hopefully for most of my career. And it's like I'm getting a little window into what I might be using in the future, what might be available to me, what the evidence might say. So it's definitely something to get excited about. I want to walk through what I think is a relatively common clinical scenario and just kind of get your thoughts on it. So let's say we have a patient who presents with confusion, et cetera. And I'm basically trying to paint a very straightforward delirium case, right? So this is an older patient. They present with delirium. We find that they have a lower urinary tract infection. We treat it. Now it's 24 hours later, and the patient is still delirious. What do we do here? Do we wait for the delirium to resolve? Will the delirium just resolve since we've treated the presumed culprit for the kind of underlying cause? Or do we do further investigation? Do we treat symptomatically? How would you recommend approaching this patient?
So first off, there are some who would dispute whether urinary tract infections cause delirium.
Wow.
So I have heard that as a perspective. The other interesting question here, and this is an empirical or epistemic question, is, we talk about asymptomatic bacteriuria. A person with delirium is not going to report their symptoms very well. So do you have burning? Do you have, I don't know. Maybe they're really confused and they can't give you that information. So again, it ends up being an epistemic question. How do you know whether they are asymptomatic? They have bacteriuria. Maybe they have white blood cells, leukoesterase, and what have you in the urine. Is this a real UTI? So that's an interesting question. So I'll add that level of complication here. At the same time, this is so common. So some people are going to say, well, you treated the UTI, or what you presume was a UTI. Empirically, you treated it, and they didn't get better. See, it wasn't the UTI. UTIs don't cause delirium. One question might be, though, why do people not get better after the proximal precipitant is out of the picture, right? So I think that's the question we have here. And watchful waiting is, unfortunately, very often the treatment du jour, right? That's what people do. But I'm going to kind of recall the three parts, kind of the tripartite model of delirium, the disorder, a moment ago, right? So we have the proximal cause, you have the intervening physiology, and then you have the clinical phenotype. So now we've knocked out the top thing. We've knocked out the thing up top, the upstream cause. The pathophysiology doesn't necessarily reverse immediately. So it could well be that although the bacterium is gone, the inflammation is still present, right? So the inflammation peripherally could still be present. There is a condition called cystocerebral syndrome, which might not necessarily be this, but when you have bladder distension, it sends a sympathetic message up kind of afferently to the CNS, and that itself can cause delirium. And as soon as you decompress the bladder, it goes away. The confusion goes away usually within minutes. I've seen it melt away when a person has urinary tract, we'll say retention, so bladder distension due to urinary retention. It's very often an irritable delirium. Once you decompress the bladder, that goes away very often, can melt away. So it could be that the person is still retaining urine. That could be another contributor. But really, at this point, if the person's still confused, I think this is where the future of delirium and whether anti-inflammatories might be the appropriate treatment. I don't know the answer to that, but again, I want to paint a picture that says the pathophysiology is clearly still relevant because the person isn't clear-minded yet. How do we facilitate healthy cognition in this person? At the same time, if they may remain really delirious, I think the clinical answer is also probably broaden the net, make sure they don't have other causes. Maybe it was actually urosepsis, and so maybe it actually is more impactful than we had originally realized. Maybe there are other issues as to why. Maybe through the delirium, they became dehydrated and now they have hypernatremia because they haven't been drinking as much free water. And so now we're getting into the physiology and how well they're taking care of themselves and whether we can support them metabolically, physiologically, functionally while we work with them toward recovery.
Okay, so having respect for the fact that just because we think we have a culprit, we may need to cast a wider net, look at it a little bit more deeply. And also, just because we've theoretically corrected the underlying cause, all of the pathophysiological manifestations of whatever that culprit is are likely ongoing and will likely require some time to improve. And as you mentioned before, some people never do return to their prior cognitive baseline. Is that right?
That's true. And another analogy, which I think is very clear as a kind of, the proximal precipitant is in the past, post-operative delirium, right? So there is anesthesia, and then there is the tissue injury that occurs at the time of surgery. So there's an inflammatory response. The body's going to try to heal itself. It will be an inflammatory response after surgery. It's not an unhealthy thing, but in some individuals, it leads to delirium. We know that postoperative delirium tends to peak in phase with the elevation in C-reactive protein. So when C-reactive protein goes up, delirium goes up, and it parallels that peak, temporally coincident with the peak in general. Now, of course, it can be a little bit dissociated, but that's the general finding. And so think about postoperative delirium. The cause is always in the past, but the physiology is in the present. And so you can't go back in time and make it so that the person didn't have the surgery. You can't go back in time and make it so that the person did not have the UTI or whatever the proximal thing is. But the thing that persists, that is perhaps mediating or catalyzing or keeping the delirium clinical phenotype alive, is still active. And so again, this is where I think differentiating the proximal precipitant and the downstream pathophysiology, the broader encephalopathy, is important and helpful because it could provide novel insights in future studies and future clinical care to address the thing that is keeping it alive. And I'm just going to say, because I love sleep research in relation to delirium, maybe it's simply that they need a really healthy, healthful night of sleep. It's like in IT. Have you tried turning it off and on again? So we got to turn it off, but you can't just turn it off in delirium. Delirium is not sleep. It's really a disturbed global cognitive state. But sleep should have certain kind of phases. You progress through different phases. You have certain discrete REM episodes, right? So in that sense, maybe it's simply that we need also to do these kinds of restorative physiological interventions that facilitate healthy cognition.
You're giving me flashbacks to being a third-year medical student and waking patients up at 4:30 a.m. on pre-rounds, 5 a.m. on pre-rounds, and thinking, I just don't know how helpful this is for your healing. So I feel for you to all of our students listening. I don't know what to tell you, but I empathize with you. I've been there. And I guess just do your best. And that's an amazing nugget about the CRP and the delirium. I had not heard that before. And I think you're just sort of showing us a little glimpse of what you think the future might hold.
Absolutely. Yeah. Again, if we dial into the pathophysiology, I feel like that's going to be, it's currently an unexplored area, but I think there's a lot of optimism currently to think that, maybe we can dissect out, again, different physiological subtypes of delirium.
Who overall is most at risk for delirium?
Because, and I'm going to say this kind of in the context of what we already talked about, we know about the final common pathway of delirium being a network dysfunction or kind of dysregulation failure. It would be presumably the people who have the least reserve of those cognitive networks and those who have the least agile networks. And so what would we find? We would expect people to have who are older, who have a greater risk of delirium. I already alluded to the fact that they happen to have a higher risk of delirium overall. Number two, people who have baseline cognitive impairment. So they're starting out kind of one rung down in terms of the cognitive coherence of the different networks in their temporal sequencing and the ability to process information clearly and remain abreast of salience in their environment. Third, people who have functional impairment as a whole tend to have greater risk of delirium, and it may well be that these are individuals who have higher frailty. There are a number of ways of measuring frailty, but higher frailty and functional impairment would predict greater risk of delirium. And two other notable populations, one would be people who have greater severity or complexity or acuity of illness itself. So, if someone has a much more severe sepsis, then they're much more likely to develop delirium versus somebody who has bacteremia, but not that sepsis response. So, right, it's the severity of the inflammation. It's the severity of the oxidative insult. It's the severity of the thing that, again, is disrupting the neurotransmitters as a whole and drawing metabolic demands away from something like the higher cortical functioning of the brain. And then the other population that I'll think about are those individuals with polypharmacy or hyperpolypharmacy. There are a lot of people with a lot, and I mean a lot, medications. And, on the one hand, we think about basic things like, the Beers criteria. So they updated those in 2023, the 2023 AGS, or American Geriatric Society, Beers criteria. And so this is identifying potentially inappropriate medications in older adults. And a variety of those are on the Beers criteria list because they can cause delirium. But on the one hand, yes, so some of them are anticholinergic, some of them are, opioids, some of them in other ways impair cognition. But when you get a lot of medications, the likelihood of drug interactions increases exponentially. And I'm not sure that a lot of us, and I'm going to include myself in this bucket, are really aware of all the many potential drug interactions that happen. When you get to 10, 12, 15, 20 medications, the likelihood that one of these interacts with another one of them is so high. And then again, when you see people with these long lists of medications, these laundry lists of medications, these are usually in older adults who are already more frail and already have some degree of functional impairment and may also have some degree of baseline cognitive impairment. And so we're really adding insult to injury at times when this long list of medications, again, conspires against the patient at times. And so deprescribing might be the appropriate approach. And there's a lot of push right now to do deprescribing initiatives. Do they really need these medications? What are we actually aiming to achieve by providing all these medications? And could we be doing more harm at times than we're actually aiming to do for good?
I love it. We may have to do a whole episode on psychiatric deprescribing. So you're coming through the list of polypharmacy, you're using the Beers criteria, you're getting to a more rational medication regimen. There are some kind of non-modifiable risk factors, advanced age, maybe things like cognitive impairment that you can't modify. You're promoting overall good brain health, things like mobility, sleep, etc. We've talked about that. Any other nuggets about preventing delirium that you think is important for our learners to know?
So I'll say this. There was a recent Cochrane review, which I think is really important to note, that about 40% of delirium is preventable in cognitively at-risk populations. This is a Cochrane review. I believe it was published in 2021. And I think that's an important consideration. I think this is one of the big things we've learned over the last, let's say, 15, 20 years, that delirium is, in fact, preventable when you use these things like delirium bundles, HELP, A to F bundle, things like that. So preventing delirium is possible and should be front and center. One thing we don't know is whether these bundles hasten the resolution of delirium. So there are no good studies where we can say, oh, if you weren't doing those things before, but now the person has delirium, if you do the non-pharm now, we're going to get it better faster. Now, of course, it would almost be kind of unethical not to give the preventive treatment and then to just give it right once the delirium starts. One could argue maybe we have equipoise, and based on equipoise, we could say we want to really allocate our resources more in a more targeted fashion. But we don't know yet whether those kinds of things hasten the resolution of delirium when it happens. But I'll push into the future of delirium. You say, what about preventing delirium? I'm really curious about pharmacological prevention as well. So I mentioned a moment ago, dexmedetomidine can prevent delirium in certain models, especially in the ICU and specifically overnight. In one particular study I'm thinking about, Ioana Skrobic was the first author, and it was a two-site study, both in Boston and in Canada. And it again, reduced the likelihood of delirium. Maybe it improved the physiologically restorative sleep at night. But there are other things that have been tried recently. There was a study, I think it was called the DEXA study, where basically acetaminophen was used postoperatively to prevent delirium. It was a four-way trial, so 2x2 and 2x2, and they had an across version. But essentially the question is, can we prevent delirium by using other forms of analgesia? So that might be one thing to think about. There have been studies, they've not been positive. The largest one wasn't positive, but maybe using gabapentin in the postoperative setting as well to prevent, again, the larger study of that, to my knowledge, was not positive, but again, thinking creatively. There was one study published in the American Journal of Geriatric Psychiatry recently looking at intranasal insulin that was positive in preventing postoperative delirium. And so the idea here is that by improving glucose utilization in the brain, you improve cognition in the perioperative space. And so again, I'm really curious to know what future models and future paradigms of pharmacological prevention of delirium might look like as we understand with greater specificity the different physiological routes to delirium.
Wow, that's amazing. So many different avenues of attack, it sounds like, as we move forward. Okay, Dr. Oldham, open mic night. Any other common misunderstandings about delirium that you think are propagated, that you've heard, that you want to correct to make sure that none of our psychiatry bootcamp listeners are propagating these misunderstandings?
Yeah, so we have another hour on this one, right?
Yes, of course.
No. So first off, I think the biggest misunderstanding is that delirium is one thing. So again, I said I'd come back to this later, but essentially dementia historically was thought of as an all-cause dementia. And it was just, you have dementia. Now we know there are many different neuropathologies that underlie dementia. And they are discrete, and they've really opened up our eyes to thinking about dementia in new and, I think, provocative ways and important ways. We wait for that to really fundamentally change care. Admittedly, it's not been an easy field to tackle, but it has given us a lot of insights into the fact that dementia is not one thing. It's many different things. So we can prognosticate a whole lot better when we know the underlying cause. Now, with delirium, again, we think of it in general. When we use the word delirium as a singular, delirium is, or what prevents delirium, or what predicts delirium, or what are the outcomes of delirium, we're using delirium in the singular, and without realizing it, we're actually implying all-cause delirium. And so again, our language betrays us at times, and it makes it challenging, but I would say big misconception, delirium is one thing. We know it's not all one thing because alcohol withdrawal delirium is a thing. And we know that's very different. It's a very different thing from other delirium that we might articulate. Hepatic encephalopathy delirium, or delirium that presents as a result of, again, like we talked about earlier, UTI, sepsis, what have you. So I challenge the idea that's a one thing. Number two, I would challenge the idea that we should look for, or that we should expect, maybe we should continue looking for it, but that we should expect to find a one-size-fits-all treatment. I don't know. I mean, if we found it, good. I would love to be proven wrong. Please, someone prove me wrong. But the history of delirium scholarship increasingly suggests, and it suggests with increasing clarity, that we're really talking about many different things under the banner of delirium. So I don't know that we should expect to find one intervention that works for all delirium and all of its many kind of physiological subtypes, as well as all of its unique neuropsychiatric disturbances. A few other things I'll add for misconceptions, and I won't cover these in detail. There is we published a paper a couple of years ago on 10 delirium misconceptions. That the title is Responding to 10 Common Delirium Misconceptions with Best Evidence and Educational Review for Clinicians in 2017. So I would refer some of the listeners to check that out.
I'll put in the notes.
They're still relevant, and I think a lot of them are still misconceptions. So it bears repeating them. And then getting to this idea of encephalopathy, a couple of misconceptions around delirium and encephalopathy that I'll add here at the end. One is that encephalopathy is a brain disease and delirium isn't. Again, I think that's a category error. Encephalopathy simply, by convention, describes the brain pathophysiology, whereas delirium, as a construct, includes both the clinical phenotype as well as the full spectrum of physiological kind of underpinnings that lead all the way from the proximal cause through the pathophysiology, namely the encephalopathy, all the way to the clinical phenotype. So again, delirium implies an underlying encephalopathy and includes it, whereas encephalopathy is restricted to the underlying pathobiology. And I'll end on this one, which is that this idea that encephalopathy is more severe than delirium. Again, I think at least even in our reimbursement models, metabolic and toxic encephalopathy are now currently designated as major complication or comorbidity, whereas delirium is not. And it strikes me as a bit strange because, again, conceptually, delirium implies underlying encephalopathy.
Wow.
And so it just seems to me that the two should be on par when we think about their magnitude of effect. And not only that, really the robust literature that surrounds delirium, rather that metabolic and toxic encephalopathy as generic categories really don't have their own unique literature that says metabolic encephalopathy is, and it predicts these outcomes, or these are the things that are risk factors for developing a metabolic encephalopathy. That's not the way the literature works. Literature clinically begins with the clinical presentation. And where do we begin? At the bedside. And at the bedside, what do we see? Encephalopathy? No. We see delirium. We take care of patients. I think the patient should be at the center of our care and at the center of our research. I think that's why, in general, I think I favor delirium and why it really captivates me clinically, but why it matters.
It doesn't get much more concrete than that. He tracked it all the way down to the nitty and gritty of the reimbursement models. So thank you for sharing all that wisdom with us. You have been extraordinarily thorough and extraordinarily generous with me. Do you have any final thoughts for our listeners?
I'll end on this. I wasn't expecting to have a final thought, but I'll add this as a coda. I've gotten into creating memes lately. And I would say, you have to add a level, you have to add a level of just lightheartedness to the kinds of things that we do all day. And I think humor is a healthy defense strategy. So I think channeling this into humor is wonderful. And so I don't know, just find ways of engaging with this in a spirited fashion that always defends the humanity of the patient and yourself and the family and what you do, the dignity of what you do. But you can absolutely and should absolutely engage even in things like this with a degree of levity and humor, because that's really important.
I love it. Use all the tools available to us to spread this message, and hopefully in formats that people will actually use, like memes and maybe even a podcast.
Totally.
Thank you again for coming on, and I can't wait to talk to you next.
Thank you.
Thanks for listening to this episode of Psychiatry Bootcamp. Please leave a rating and review. If you have questions or feedback for me, you can email me at psychiatrybootcamppodcast@gmail.com. The opinions shared in this podcast do not reflect the opinion of any institution, including host or guest employers or podcast partners. This podcast is not intended to be used as medical advice or in any legal proceedings whatsoever, including to establish a standard of care. This podcast is intended only as a supplement to a complete, accredited psychiatry residency and is grossly inadequate to rely on for medical decision-making. It is intended to entertain and inform. You should always rely on your own clinical judgment when making medical decisions and contact your physician for medical advice.